Hello, welcome everybody. My name is Dervla Hogan and I'm a member of the National Quality and Patient Safety Directorate team, and I'm delighted to take this opportunity to welcome you to our 6th QPS talk time of the Spring-Summer 2023 series. So I suppose we have an extremely exciting session for you today. In and around the revised HSE policy for safe surgery. So we're going to be discussing what's new there, what does that update bring, going to be looking at e-learning, new e-learning opportunities, and we're also absolutely delighted to be getting insight from a pilot that was completed in Ireland East Hospital Group in relation to adapting these templates for new briefing and debriefing stages. We're also going to be provided with an overview in and around the poster in relation to management of unexpected intraoperative life-threatening hemorrhages. And most importantly, you're all going to have a wonderful opportunity to connect, ask questions and learn about experience from our specialist panels. So I'm just going to take this opportunity now, which I'm absolutely delighted to have the pleasure to do, to present today's speakers and also the panel members. So firstly, we're going to have Aileen O'Brien, who's Assistant Director of Nursing for the National Clinical Programme for Anaesthesia. Aileen will be first to present. Anne Jones, Aileen will then lead on to Anne Jones, who is a nurse lead for quality and patient safety improvement in Ireland East Hospital Group. And finally, Dr. Joan Power, consultant haematologist, will close out the presentations. Our panel, along with Aileen, Anne and Joan, will also include Miriam Kennedy, who's project manager for the Guideline Development Group, and Ciara Hughes, program management manager for the National Clinical Programme for Surgery. And the co-hosts for this session are myself, Dervla Hogan, and my colleague, Maureen Flynn. So I am now absolutely delighted to hand over to Aileen O'Brien, who will start by providing an overview of the updated safe surgery policy. Thank you, Aileen.
Thanks, Dervla, and good afternoon to everyone. I'm delighted to be here today to share the key points and the updates from the HSE Policy and Procedure for Safe Surgery, which was published and launched in September of last year. The 2013 policy was reviewed and updated by a working group of key stakeholders, including the National Clinical Programmes for Anaesthesia, Surgery and Trauma and Orthopaedic Surgery, HSE Quality and Patient Safety, Acute Operations. There were representatives from all hospital groups and patient representatives. And research has shown us that surgical safety checklists are effective interventions that have been shown to improve patient safety. This revised policy endorses the principles of the World Health Organization's Surgical Safety Check, Safe Surgery Saves Lives, and the HSE Patient Safety Strategy. And I suppose one of the common themes running through these three documents is that there is no single solution that will improve surgical safety. It does require consistent execution of a sequence of necessary steps, and not just by the surgeon, but by the team of healthcare professionals who are working together for the benefit of the patient. The UK Healthcare Safety Investigation Branch in 2021, they highlighted that checklists alone will not prevent incidences from occurring, and a collaborative focus should be placed on ensuring safe practices in addition to using the checklist. This current policy applies to all patients undergoing surgery in the Irish hospital setting and all healthcare staff involved along that surgical pathway. It can also be adapted for all clinical interventions in clinical areas outside of the operating department. So what is new with this policy? Well, first of all, we've added two new stages, which are briefing and debriefing. And the briefing stage allows for the plan of care to be discussed and agreed. It also assists with fostering a culture of open communication, and it facilitates the transfer of critical information. It should be conducted at a locally agreed time within the clinical area where the procedure is to take place, and should also be attended by all members of the operating team. Debriefing should take place at the end of the surgical list, and this gives the team an opportunity to review the procedures of the day. It can include any critical instances that may have taken place or any equipment issues that need to be addressed. And it also gives an opportunity to discuss the achievements and what went well for the day. We're often, very good at saying what didn't go right. We don't actually, pat ourselves on the back and say we did a good day's work. And debriefing, it also increases collaboration of all team members. The policy itself sets out a standardized approach to improve patient safety by providing a structured process and framework for the teams to discuss the plans, communicate, and address any concerns or critical points along the patient pathway. It includes the agreed minimum safety checks for the sign-in, time-out, and sign-out stages. Each of these stages provides a trigger to complete steps aimed at optimizing patient safety, and each of the checks is included on the basis of clinical evidence and expert opinion, and that it will reduce the likelihood of serious avoidable harm. The WHO outlined the 5 stages along the pathway where effective teamwork and communication are essential to reducing risk to the patient, and this policy has adapted those 5 stages. It promotes teamwork and communication, which are both essential components for patient safety. There are also a few variations within this policy. So first of all, a template was developed for patients who are requiring local anesthesia only, and this is a simplified version combining both the sign-in and the time-out stages. Another variation is prior to the administration of a nerve block, a stop before you block check must be completed. If more than one surgical procedure is being carried out, or different surgical teams are performing procedures on the same patient, a separate timeout must be completed before each procedure commences. The other thing we've included is a check asking if the risk of expected and unexpected blood loss has been discussed. And this is in line with a recommendation from the guideline for the unexpected intraoperative life-threatening hemorrhage, which Joan will talk to you about. So while we were developing the policy, a requirement for a national education and training tool was also identified. And the development of an interactive education tool, which will be hosted on HSELand, is near completion. That is due to be launched next week on the 26th of April. It'll take approximately 45 minutes to complete. It does have knowledge checks and assessment throughout the module. It will have CPD points, and it is transferable between hospitals for staff that are moving. The key messages throughout this module are to respect the process and play your part in the 5 stages for safe surgery. Now, we all know that clinical audit is an essential tool for improving patient safety, and the policy recommends that audit should be conducted biannually. The recommended audit tool within the policy contains a mixture, I suppose, of structure and process. And this examines if the processes are being followed and how the completion of the checklists are actually being carried out in practice. It is recommended that 70% of cases will be audited retrospectively, and 30% will have a concurrent observational audit conducted. The recommended sample size is between 20 and 50 cases. And the audit schedule needs to include time as well for analysis, reporting, and implementation of any quality improvement if it is required. The aim of the audit is for 100% compliance, and that is what is recommended in the policy. Audit of this HSE policy has now been added to the HSE list of healthcare audits planned for acute operations in Q3 of this year. Thank you very much. I now hand over to Anne Jones, who will share with you how the Ireland East Hospital Group are implementing the briefing and debriefing stages of this policy.
Thanks very much, Aileen, and good afternoon, everyone, and lovely to see so many joining us online today. I'm going to talk a little first about the science of how we implement evidence into practice, really about how we manage that evidence to practice gap. And then we'll look at that in terms of our progress to date in regard to the implementation of the updated World Health Organization guidance as set out in the policy and procedure for safe surgery, and in particular, as Aileen says, in regard to the brief and debrief steps. So new evidence comes all the time. We see it in research papers and literature, and in the policy and guideline documents that are produced locally, nationally, and internationally, like the WHO guidance that we're discussing today. The challenge is, of course, how can we ensure that all this new evidence gets embedded into the everyday practice of busy frontline staff? Interestingly, the literature tells us that it can take up to 17 years to get evidence-based practices fully implemented. And extraordinarily, only about half of evidence-based practices ever get fully implemented. If we look at the processes that we generally adopt when new evidence comes to light, we have very good dissemination processes. We communicate about new policies or procedures. We might hold launch events. Sometimes we develop tailored information or education sessions, or we can direct people to ready-to-go education programs like those on HSELand. We're familiar too with many quality improvement processes, and we have our QI toolkits and ways to redesign our processes and systems when change is required. But all that of itself won't ensure that we get staff buy-in, or that we'll get meaningful engagement or commitment, or be successful in embedding and sustaining the new processes that we implement. So what are we missing? Implementation science, we're told, is a scientific study of all the methods available to us to promote the implementation of evidence into practice. It shares some common characteristics with both quality improvement and dissemination, but it's distinct from them. If you like, it's the missing piece of the jigsaw, and therefore it's an equally necessary part of our implementation process and plans. Implementation science provides evidence to support the types of elements in this word cloud. Interventions which we can consider to be common sense and which we can easily assume will happen automatically. And so we don't necessarily consider that there's a whole scientific field of evidence to support the importance of each of these types of measures. And we don't necessarily stop, for example, to consider how will I engage every single staff member in this department to gain buy-in into this new process. With implementation, we need to always start with an analysis of the context, the culture within the particular department, and then develop the unique package of interventions that will work within that particular context. Tools like the Framework for Improving Quality can guide our processes, but when we get to the step on staff engagement, we need to consider the guidance from the whole field of implementation science and choose from it our bundle or our particular package of interventions for the particular setting. So how does this all support us in implementing the World Health Organization guidance, which advocates for a team brief and a debrief to take place for each theatre list, using a standardized template and following a structured approach? That's the challenge to us. In the Ireland East Hospital Group, a subgroup of the Theatre Managers Committee was set up, which included representatives from 3 theatre sites to work on designing and piloting a process to address this challenge. And following a series of PDSA type cycles, a final format for the document was agreed. And just to explain the changes to the format, and they're highlighted in pink there on the bottom left of your screen. So HCAs were added to the list of staff present, as they are key contributors to the smooth running and therefore to the safe running of the list. Just from a practical perspective, the start time was moved to the right of the brief document so it could sit beside the finish time on the debrief side, as it was thought that this alignment might assist with reviews of efficiencies in regard to the use of the time slots. But the other key change was in the section on concerns raised. At the end of the brief document, the original had 3 columns to indicate which discipline raised the concern, but this was considered by the group not to have relevance, and the 3 columns were amalgamated to provide greater space for documenting the actual concern raised. This whole process of engagement with the theatre users was then overlapped by similar PDSA type cycles with the printers until the final format was agreed, which consisted of a book type version of the document, and you can see our book here on the right of the screen. In mirroring the science, which we've talked about surrounding implementation processes, a number of steps were adopted in order to implement these 2 important additional steps into the theatre routines and thus to achieve safer surgeries. And these included partnering and using local knowledge for co-production of solutions, the PDSA cycles which contributed to buy-in and ownership of the process, the development of the book type format as described, which acts as a physical reminder and as a forcing function within the normal routine. The pilot phase, where we demonstrated trust in the local problem solving and based the implementation approach on each local context. The provision of feedback forms throughout the pilot phase, facilitating and encouraging staff engagement. The results indicated that there was consensus on the importance of the process, with views expressed that it should be rolled out to all areas. Some local informal leaders emerged, which assisted greatly in driving the implementation. And one of the sites commented that the process implemented surpassed their expectations. There was some key learning for us also, and this was particularly in 2 regards. Firstly, the need for leaders to maintain focus on the process throughout the whole implementation. And secondly, the importance of continuously engaging all involved. So to our next steps. So the national audit process, which Aileen outlined, will support the quality improvement aspect of this initiative. And the e-learning programme, which is about to come on stream, will significantly support our dissemination processes through the provision of widespread staff education. The e-learning programme, though, will also support the implementation process through generation of insights and through motivation of staff to engage. And then additional engagement processes will be required in regard to the rollout to the sites, in regard to the adequate supply of the books, and in regard to embedding of these 2 new steps within the routine processes in all of our theatre departments. So I'd like to thank you all for your attention, and I'm now pleased to hand you over to Consultant Haematologist, Dr. Joan Power.
Thank you very much, Anne, and good afternoon, everybody. I'm delighted to follow on from those 2 very relevant talks to a discussion on the guideline that has been developed by a multidisciplinary group. Aileen was co-author, as I was, and we have Miriam Kennedy, project lead, on the panel discussion also. So specifically in relation to this unexpected intraoperative life-threatening hemorrhage guideline, which was published last May, we hope, good aid to implementation in the national poster. So I just want to talk through the evidence that informed what we put into that poster, what the content was, and specifically the focus on its multidisciplinary development of a guideline, because all disciplines are actually involved in unexpected intraoperative life-threatening hemorrhage. So it's a NEC guideline, and so it's Department of Health, and it was ministerially commissioned after a tragic, fatal, unexpected intraoperative life-threatening hemorrhage. This is an adverse event that is a key concern in health, and developing this guideline facilitates a quality improvement process for your hospital to reduce the damage and harm that has caused, the morbidity and mortality associated with this. We know about 1/5 or so of unexpected hemorrhages are intraoperative. The vast majority are unexpected, and a significant number of out of hours. So anything of a 40% blood loss is life-threatening, and it requires immediate management to both deliver oxygen and prevent and manage coagulopathy. The mortality rate is about 10% in the survey we conducted through the RCSI in 2018 in Ireland. It was 11.5% for 2018, but this rises to over 30% where there's a delay to transfusion. And this is the multidisciplinary communication across the whole of hospital really to affect a proper and appropriate response to a life-threatening hemorrhage. The objective and scope of this was to develop a guideline within a national framework that was relevant for all sites, all hospital sizes and sites with various laboratory supports. So we wanted to introduce unnecessary variation in practice, provide an evidence base for the most appropriate healthcare. And that consistent approach we wanted to have across all sites, that there was very clear communication as to what actually was happening, that it was a life-threatening hemorrhage. And as has been spoken of in the previous talks, it's not just the event, it's the whole of the background and the preparation and the structures and processes that are in place to actually have this prepared for and managed as best possible. So we were looking for evidence base for recommendation for theatre staff, for laboratory and other staff on the prevention, the recognition, and the timely response and management of life-threatening hemorrhage. We looked to an anticipatory definition. There is no point in looking at something 3 hours later to say, did it qualify by way of requiring 5 units of red cells? So it was clinical impact of ongoing uncontrolled hemorrhage. So this is a new approach. The activation is following rapid identification of actual or suspected major hemorrhage, because sometimes hemorrhage can be concealed or the impact may not be so obvious with anaesthesia. And looking at a prompt response, like any other resuscitation, it needs that prompt response, so there's no delay in the management of patients. And looking at the Haemovigilance system in the UK, the serious hazards of transfusion, or the SHOT systems that some of the Haemovigilance staff on the webinar will be familiar with, very good feedback as to what's causing these delays. And the first key area is poor communication. After that, it's also delayed recognition, the human factors. This can't be happening to me, or unfamiliarity with what happens in this circumstance. Delay in activating and accessing help, moving patients, delays in the laboratory, like not getting your sampling right, and delays with the actual transfusion. So in terms of management, again, it's a system approach. We have to look at prevention and preparedness. And a lot of this comes in now into the new checklists that have been talked about. So the policies, the protocols in place, the communication that's agreed in advance, and the documentation. And as I've mentioned, you've added to some of those in the recent updates in terms of documentation. The pre-op risk assessment for individual cases, really important, and looking at what the blood order schedule is, and not only is it ordered, but is it actually available for you. So timely access to transfusion support, really important that you're aware of where it is, how quickly it can get to you, what kind of blood can get to you quickly, and what's the turnaround time of laboratory testing, or what's the position in relation to near patient testing in your hospital. It is an emergency. We need to have a very clear language that everybody understands. So we're terming it as code red, we're activating code red. And obviously that's a very immediate response. The bleeding has to be controlled, the patient has to be assessed and resuscitated. And then we're looking at the hemostatic resuscitation. There has to be a defined communication pathway to the laboratory, clear, one person doing it, closed loop communication, so the laboratory can respond in an optimal way, release blood in a timely way, with empiric blood transfusion initially, with massive hemorrhage packs after you've used the ONEG that's available to you, or indeed if you have a blood order for that individual patient. You're going to be monitoring the patient closely with laboratory testing, as well as the clinical and cardiac and metabolic monitoring. And you'll need to do repeated testing over that period of time to understand how advanced or otherwise the coagulopathy is in particular. So empiric transfusion protocols are there for that immediate response. Firstly, you're going to go to your ONEG if it's immediately available to you. You will know from the poster where it is in relation to your theatre. You will also have opportunity for some patients to have some blood already there if it's cross-matched and available for the patient. But the laboratory, once you call it code red, the laboratory will respond with a massive hemorrhage pack. you'll be giving tranexamic acid immediately in this circumstance. And I think we're all aware of the function of our various blood components, our red cells, managing tissue oxygenation and preventing or managing coagulopathy. Our plasma will obviously improve our coag and also help the endothelium, but we really do need fibrinogen because the level of fibrinogen in our plasma is quite low, and it's available to us as a concentrate. Our platelets usually come in late on after we've had a 1.5 blood volume loss, but if you're in a hospital where platelets are at a distance, you don't have them available to you, they need to be ordered in, and they're ordered in early so that they are available. And of course, we have the complication now with 15% or more of patients who are anticoagulated. So all of that has informed what we have in this poster, which is coming very soon to a hospital near you. There has been a communication that the National Quality and Patient Safety Directorate has been engaged with to hospital managers and CEO to ask them to identify responsible persons to lead out the managing of the poster at each service site for each individual theatre that they have. And that may be across a few hospitals. This will be followed up with the circulation of the poster to the hospitals and an engagement with those local stakeholders for local data capture on the poster. The poster is to be displayed in each relevant surgical site or room, and there will be support for this in terms of an e-learning and FAQs and other supports available. So effectively in this poster, we have our initial if we like, an initial focus that this is a code red emergency. It's a clinical concern that actually triggers the code red. We have a senior clinician who tells the team in theatre, I am activating this. They're not talking to themselves, they're letting the team know what's actually happening, and they identify an emergency coordinator. And that may well be one of the nursing team in the hospital, in the theatre. So the surgeon is going to be concerned with controlling the bleeding and stopping the bleeding on the left-hand column here as we come down. And anesthesiology are going to be engaged with resuscitation. So identifying the coordinator, that coordinator is going to identify a communication lead who's going to be the interaction between theatre and the rest of the hospital. So that is initially with switch or bleep, whatever system is already agreed in your hospital, the communication with the laboratory, calling for help in all the various ways that are required, senior staff, etc., all set out as a prompt, and the phone numbers for the various laboratories or other help to be called displayed for your hospital on your poster. To the right-hand side here, we have our initial engagement. Obviously, tranexamic acid is used immediately, and we'll note where that's available to you, followed by either O-neg blood or the blood that's specifically requested for the patient in advance of surgery, if that was the case. In most cases, it probably may not be individual patient blood there. So the laboratory staff member or the communication lead will then be in communication with the laboratory to plan the samples that are required, activate code red, get the hospital emergency pack out to theatre with 4 red cells and 4 platelets in it, and look at fibrinogen, etc. So this really is the prompt around the ongoing bloods that are required, and as the situation progresses, looking at pausing and review across both sides. And as we progress here, we may need platelets if the blood is bleeding is ongoing and uncontrolled. And we set out here what are the targets for our platelet count, our fibrinogen, etc., hemoglobin, etc. And again, prompting about managing metabolic risks. And underneath here at the end of the poster, the link that we will have will be to agree what you will have for your hospital here. You will know where the nearest O-neg blood is. You will know whether there's a fridge beside you in theatre or where it is nearest to you. What's the location? How quickly can you have it? You will know whether you're using a transporter in theatre or not. That might be available to you. In terms of red cells, outside of the massive hemorrhage pack, so when we're finished the empiric blood support, when we start to actually have blood available specific to that patient, you will know what time it takes to have blood that's group specific for your patient or cross-match for your patient in your hospital. Equally with plasma, whether you have thawed plasma or it needs to be 20 minutes or 40 minutes, whichever it is, in your hospital to be thawed, and platelets, Have you them available? How many do you have available? So you're prompted as to when you need to ask for it. Equally, with our other components, our derivatives, our tranexamic acid, our fibrinogen, where are they that you can access them immediately? And again, our management of reversal of anticoagulation. So the poster is looking to be an aid to you implementing this guideline with all of the key aspects, particularly managing human factors, so that we can reduce that mortality down from a 30% down as near to 10% and less as possible. So that's the overview that I wanted to present today. Thank you very much.
Thank you, Joan, and thank you, Aileen and Anne as well. The three very, very interesting presentations. So I suppose we're now at the stage where we'd be very interested in getting any thoughts, comments, questions, etc. into the chat. I think some have been coming in already, Maureen. But I would just, while Maureen, you're having an opportunity there to pull some of them together, I'll just, we're bringing back the panel together. So I'm just welcoming back Kira and Miriam, along with Aileen, Anne and Joan. And I'm also absolutely delighted to welcome Professor Bryce and Tao, who's the consultant paediatric surgeon and paediatric network lead with Children's Health Ireland. Welcome, Bryce. So I suppose while Maureen is just gathering some thoughts from the chat there, and please do keep sending them in, just while you were presenting, I was having some maybe practical thoughts myself that some attendees may want to know about. So I suppose even Joan, just on the back of your last presentation there, where can people get the poster? I know you said it's coming soon to a theatre near you. Just for attendees, how can they get access to that?
So we have been in contact through Miriam and through the office with the CEOs and managers. So we've asked for a link person for each hospital or for each surgical site. So Miriam may have an update as to how many responses we have. There are 45 transfusion laboratories, but many of those will cover several sites. And obviously within sites, there are many, many theatres. So Miriam might have an update as to what the response level is looking like now.
Thanks, Joan. Yeah, we've had a very good response right now, and we're almost there. We've got updates from across all hospital groups, and we just want to finalize our numbers just to up it a little bit more. And hopefully by the end of this week, that's a target that I'm aiming for, that we finalize our contact list. So we're almost there, Joan.
That's great. So with that contact list, Miriam will be in contact with those link people. And they have the ultimate responsibility, obviously, is with hospital management, but they can't do it without all of us working with them. So the link person will be the facilitator between theatre, the haematologist, the laboratory, etc. So that we can get that information for individual hospitals and get the poster displayed through all of the theatre sites.
That's brilliant. Thanks so much, Joan and Miriam. So another thing that just came up while you were talking there, Joan, was that thought of staff engagement and responsibility, and just linking in with the patient strategy there as well. Just going back to Aileen and Anne, I'd just be really interested about that engagement and responsibility piece. So, you know, Aileen, I suppose from your experience initially, I was just wondering if I could ask you about who is going to be taking responsibility, who should be taking responsibility for the implementation of the revised policy.
Thanks, Jordan. A very good question. And I suppose, the responsibility lies with all of the members of the operating team. The previous policy had nurse coordinators that they assigned the roles of the completing the sign in, the time out, and the sign out to. The group made the decision that it is everybody's responsibility, not one person's. And that's what we're trying to do, in that everybody should be responsible for it. Bryce might like to come in there. Bryce was on the development committee with us, so it's great to see you again today, Bryce.
Yeah, no, thanks, Aileen. Yeah, absolutely. It is a safety policy that everyone in theatre needs to own that policy, because it's about safety. And previously, when you had one person assigned to the task, it was felt, oh, it's that person's responsibility, but everybody else, you suggest sort of, stand back. But I completely agree. I think one of the discussions we had when we were putting this policy together is that sometimes people were reluctant to put their name down and sign, feeling that they would be held responsible. But once everybody within that theatre environment owns that policy and takes responsibility, then there's one person, obviously, who will be the senior person there, who will be, ensuring that they read things out. But ultimately, it's everyone's responsibility within theatre to ensure that the policy and the checklist, everything is done properly.
And I'll come to Maureen there now, I think.
Thanks, Dervla. Could I bring in a question from the chat box, which is from Laurie Martin, and Laurie is one of our colleagues in Northern Ireland, and she's sharing with us that they've used the checklist for numbers of years, but the debrief is the most difficult to achieve. And have you any tips or thoughts on how, in terms of engagement, you get to achieve that debrief phase? But she says we've never found a good time to perform it, although we all agree that it's crucial to improve.
Yeah, and I suppose on that, everybody agrees that it is essential and beneficial, and it is finding that time. Some sites find it difficult, particularly if they're doing, emergency surgery, where they will have different surgeons doing different patients during the day. And the debrief needs to be carried out with the team who has operated on either a single patient or that list of patients. Anne might be able to give us some insight into this with the pilot.
Yes, and I suppose on the engagement piece, I suppose, ultimately the degree of success you have in implementing any change depends on the degree of engagement that you achieve. And, there isn't a prescriptive process for engagement. There isn't any one approach that'll fit with all contexts. But that being said, your starting point needs to be about communication and creating an understanding of the why, what's the purpose in doing that. So I suppose, in terms of the debrief, it's trying to sell that message and the significance of that message to people. And, we mentioned the power of the informal leaders and the peer influencers. And, within every discipline, there will be the early adopters, and they'll be your easy win. So work with them to develop your ways of getting everybody else on board in terms of carrying out that debrief piece. And, that engagement with people to follow on and complete that rarely happens without effort. But if you can bring the team with you, and particularly different people from the different disciplines, then that'll help to maintain the focus and the energy and the momentum to drive that piece. And I suppose it's communication. It's getting people to understand the benefits of that debrief piece. And we talk on these lunchtime talks about the benefit of understanding when things go well. And so that's the piece of capturing that in your debrief piece, so that then when things don't go well, that you have your template for what was good when things did go well.
And that's really lovely insight. Thank you. And I'm curious, having the actual template then, is that helping people to focus on the debrief? And there's 2 or 3 questions in the chat box on the template, so I'm going to just mention those before we go into the responding. So, is briefing and debriefing the same as the theatre huddle? Some people are operating a theatre huddle, so that's terminology, so you might just think about that one. And then, will the booklet that you're adopting be a separate document in its own right? That's another question we have. And another question is where to store the briefing document. And the final question is, anybody got experience of using the document where there's an electronic health record? So there's a series of questions there. The terminology, is it a separate document, where to store it, and experience in using it electronically. Thank you everybody for your questions.
Well, I take that,
Yeah, go
Aileen?
ahead, Dan.
I suppose the first thing is about the existing huddle that people mentioned, and what the policy and procedure for safe surgery would say is that you need to follow a standardized template and have a structured approach, and that's what having a form to guide you does. It means that every day your brief and your debrief are going to follow the same process. The piece about the separate book is, yes, it does need to be a separate piece because it's about the whole list. So it can't be added on to the piece that you're already filing into individual patients' charts, because it's not relevant to one patient chart. It's relevant to the whole list. So you do need that separate process. The idea of the book is just that it's a solid structure, and it is that forcing function. It reminds people and it prompts people to engage with it, and it's the evidence that people do engage then when you have the look back and the audit. And that is to get away from people having to remember to take out a separate page of paper, fill it in, file it away somewhere. And across our site, we don't have the electronic record by and large, we've only progressed the pilot to date, so we haven't had the experience of electronic records within theatre.
Maybe our colleagues in Ireland, in the Children's Hospital, where you will be moving to an electronic health record, have you thoughts about how it will be incorporated there? Thanks, Bryce.
Yeah, no, I mean, we are moving in, and we've already. I was the chair of revising the policy within CHI, and we did check on the current sites. Is there a way to incorporate the old system that we had with the new system into current templates? And it is possible, and that is something we could build into the entire electronic electronic health record when we go down that route, because you cannot just, because you have an electronic healthcare record system, do away with the safety element of it. So absolutely, I think any electronic health record system within any health service would need to have a system in place that incorporates all the safety measures of the checklist and the policy itself, whether it's briefing or debriefing. One of the things we looked into was same thing. When you're having the briefing and debriefing, we do have an electronic theater where everything enters into the system, is to be able to populate the same sort of a template that things could be entered into. Currently, it's you could generate a hard copy that people will read through and write on it, and that goes into a folder. But when you're completely electronic, it's finding a means of putting that into an electronic system that stays in place. Just coming back to the earlier question, and you touched on that really well, is in relation to briefing and debriefing. I think one of the discussions we had when we were sort of putting together the policy was that the operation or the procedure ends when the child actually is out of the operating theater, from the anesthetic side of things, because people feel like even me as a surgeon, that once the operation is done, that's it. But the entire safety is when the patient leaves the operating theater. And I would say there's no right time that people could pick and say that's the right time for debriefing. But like a lot of things, when any new aspects of a policy is put in place, there's always that element of resistance. Oh, this is going to add extra time to what we do. And the same thing happened when the policy was first introduced in Ireland. It was always going to add another half an hour to our overall theatre time to even do a checklist. But then gradually, once it becomes a part and parcel of an organization's safety policy, the buy-in is there, and it's gradually something that will initially, it's a new concept, but people will gradually buy in, just the way the briefing at the start of going through the list. All those things have been built up over a period of time, and I think the debriefing would be one of those components of the safety policy that gradually will be a part and parcel of a day-to-day working routine within every operating theater. I hope that answers the question, and I'll be happy to clarify.
Thank you. That's really helpful. And I see lovely chat going on in the chat box between our guests too, sharing experiences. So thank you very much for doing that. We're just coming to an end, Derfla. Is there anything that you want to add before we close out, or any of our panelists who've had ideas or eurekas as we're in conversation?
I would definitely defer to the panelists, because I think that's who people are here to hear from. Aileen, I think you have something there to add.
Yeah, and I just saw a question there as to where the checklists are available. I've put the link into the chat box. They are available to download all of the checklists, including the policy, and the audit tool as well is available to download, the recommended audit tool. So I've put that link into the chat box.
Thanks, Aileen.
Aileen, so the audit tool is there as well,
Yes.
which is, there's been a few questions about the audit tool, so that's available.
Yes.
And people's contact details, if anybody wants to follow up with the panelists, I'm sure people would be happy to continue the conversation offline. We've whetted your appetite for this really, really important topic of conversation around safety during surgery. And we're really looking forward to maybe a further QPS talk time on the topic, to hear how people are adapting and using the posters for Code Red. And thank you particularly to Joan and Miriam for sharing your experiences and keeping us all in anticipation of what's coming next. So thank you all very much. On our QPS TalkTime audience perspective, including colleagues who've joined us from India and Peru, we would just like to say an enormous thank you to our guests and panelists who so willingly have shared their time. This session is recorded and it will be made available on the NQPSD website along with the slides. Numbers of people have asked for copies of the slides. So just one or two short announcements. We have a Quality and Patient Safety Prospectus. The QR code there on the screen allows you to snip to it, which is a whole series planned across the year of education and learning programs around topics related to quality and patient safety. And they're all collected in one document in one place. So just bringing that to your attention. Many of our guests today have mentioned human factors, which is very much associated with a safe surgical environment. Our understanding of human factors really helps us in keeping the environment safe for patients and staff. So we have a 20-minute e-learning program on HSELand. So when you're logging on to do the new program coming on surgery, you might also want to look at the program on human factors. It's a short 20-minute self-paced e-learning program. And we have just tested a one-day foundation in human factors, and that will be launched very shortly. Related to that, many of you online may have participated in the SAFE collaborative that we commission and is provided by the RCPI, which is the Situational Awareness for Everyone collaborative. Any of you who've completed the collaborative, we have a learning day coming up on the 4th of May. In person in Kildare Street, so you can the link will go into the chat box, will be in the slides. But most importantly, that's a learning day for anybody who's already participated in the SAFE collaborative. Applications for the collaborative starting in September 2023 will open shortly. So watch that space. And if you follow us on Twitter, you'll see details being shared across our Twitter platforms. So just a reminder, we have the QPS Ireland network map. The link is on the slide there. It's open to anybody who wants to just put their name on the map to say, I'm interested in quality and safety in Ireland. And by joining the map, you can identify who you're connecting with and working with across Ireland. And then the map acts as a directory where you can search and find individuals, their email and Twitter contact details. Separate to that is applying to become a member of the Q community. So that's an international organisation across the 5 countries of the 4 of UK and Ireland. 5,200 people who are members of the organisation called the Q community. And there's an application process and the link on the website. It's open to anybody in Ireland whose experience of leading improvement to apply to become a Q community member. And many of our guests today are already Q community members, so they can tell you the advantages of being a Q community member. So just our next lunchtime QPS talk time is on Tuesday, the 2nd of May. And the topic we're going to be focusing on for that session is patient partnerships. And we look forward to welcoming Mila, Nicola, Patrick and Breed, who will be our guests for the QPS talk time on the 2nd of May. And finally, you can follow us at QPS TalkTime, our Twitter account. You can log on to our website, or you can watch back on YouTube the recordings of it. We have a back catalogue going back to 2016 of all of our QPS TalkTime recordings. And finally, a big thank you to Anne, Joan, Aileen, Kira, Miriam and Bryce for taking the time to be with us and share your experiences and expertise today. Don't forget our little short survey as you close out. Hope the rest of your day goes really well. Thank you, everybody.